All right. Hello, everyone, and welcome to our first session of the Coding for Value-Based Payment Learning Forum. We've got 5 sessions that we'll be hosting every 2 weeks through the end of April. And what I'm sharing right now is the forum overview. So the purpose of it is just to provide information to all of you so that you can enhance your clinical documentation and coding practices so that you get the most out of those contracts that you're in right now. And with that, I will turn it over to our presenter, Shelley Sulzberger, who is owner, along with her husband, of Coding and Compliance Initiatives. Shelley, welcome.
Yes, hi, thanks everybody for having me. I'm going to go off video just so it doesn't skip. And as I'll put up the PowerPoint. And then as we go along, if you have questions, just put them in the chat. Somebody can let me know that there's questions in the chat. They can ask me, stop me along the way. And then we'll have time as well for questions. Okay, so I'm going to share my slides here. Perfect. So today we're going to talk about diabetes and obesity coding related to value-based healthcare. For those of you that don't know me, my connection to coding and documentation is I am a consultant. I work with health centers all over the country, helping them with coding, documentation reviews, best practices, shadowing. I am a nurse by background, which helps to look at those documents and educate providers. I'm an ICD-10 trainer. And as I said, I work with health centers all over the country. So that is my connection back to you. So today, during this diabetes and obesity value-based training, we're going to talk about how to effectively document and code for various conditions related to diabetes, as well as for obesity. And then because some key strategies to improve clinical documentation. So when we're thinking about diabetes and documentation, there are several things we really have to consider. Number one, we need to know if your patient is a type 1 or a type 2 diabetic. We need to know if the diabetes is controlled or not controlled. And from a documentation perspective, providers should not be using the words controlled versus not controlled. Payers don't recognize not controlled. There's not a diagnosis code for uncontrolled diabetes. The American Hospital Association has published that providers have to specify either it's hyper or hypo when that patient is not controlled. Coders can't go by the hemoglobin A1C or anything like that. We can't always assume not controlled means hyperglycemia. So for you as a provider, it'll be really important that you document hyper or hypo if you determine your patient is not at goal or not controlled. We need to know if your patient has any manifestations from the diabetes, and if so, what are those? We also need to know if your patient's on long-term insulin. We also want to know if the patient has any amputations, foot, toe, ankle. Those are often missed, and some of those amputations or required absences are HCC codes. So we want to make sure to capture those at least one time per year. So when we're looking at some documentation, we want to make sure that when you document your note, that the documentation includes that you are supporting through that note that the meat. So is it monitored? Is it evaluated? Is it assessed? And is it treated? So when we're looking at this note, for example, patient's here to follow up on diabetes. She takes her medications as prescribed or her metformin. She checks her blood sugars. They range between 75 and 130. Her last hemoglobin A1C was 8.2 from March 10th. So when we look at this, we're starting to see that evaluation portion of the diabetes. And then in our assessment and plan, diabetes with hyperglycemia, what's the plan for the patient? Continue the metformin. We talked about increasing her metformin. She's adamant about improving her diet and exercise, etc. So for this example, we see there's an evaluation. We see that there's an assessment, there's a plan. We see that the documentation of the hyperglycemia is documented to the highest level of specificity. So from a coding perspective, we would report our E11.65 to indicate that this patient is a diabetic with hyperglycemia. Now, when we're thinking about complications related to diabetes, patients can have kidney complications, neurological, circulatory, etc. There's several complications. A lot of times what happens is when I shadow providers, they are referencing some of these complications, or they're looking at, hey, when did you follow up with nephrology, etc. They don't always document how the complication impacted the diabetes or vice versa. So it's really important from a documentation and billing perspective, and to get credit for your value-based healthcare, that when there is a complication of the diabetes and it's impacting your decision making, which would be almost every single time, we might need to make sure that somehow that information is documented and connected in your assessment plan. So in our subjective portion of the note, I always say that this is the patient's story, right? We are going to get that patient's story by asking certain questions. So we might talk about, the presence or absence of any kind of symptoms related to diabetes. Are they, peeing more? Are they thirsty more often? Things like that. Are they having any numbness and tingling? Obviously, if there's no symptoms, we're going to document that. We might also ask, are they taking their medications as prescribed? Are they checking their blood sugars? What do those run? So questions you or your team would be asking the patient to get their story is my subjective portion. There are no required elements. You don't have to have X number of HPIs like you did in the old days. So we are just trying to determine in this section what you're seeing the patient for and kind of what's going on. This starts to paint a picture for an auditor to determine the complexity of the patient. How complex are they? What underlying conditions do they have, etc. The objective portion is your physical exam findings. So again, depends on what you're doing that day. Are you doing a foot exam? Things like that. So again, just making sure that that's clearly documented. Again, there are no specific requirements for the exam portion. It has to be clinically relevant. When we get to the assessment, this is where we want to start seeing the diagnosis related to the highest level of specificity that you addressed during that encounter, and anything that impacted your decision making or there's a connection. This is where we're starting to hear your story, the assessment and plan. So my assessment is what's driving a lot of my value-based care. My assessment is what is driving my E&M code. So in this section for diabetes, I'm looking to see, do they have type 1 or type 2? Is it without complications or with complications? And if it's with complications, I need to know what those complications are. Is it with hyperglycemia? Is it with chronic kidney disease? Is it with neuropathy? Is it with retinopathy? Kind of what is going on with that patient? So making sure that that's clearly documented. Do they have a diabetic foot ulcer? Making sure that you are connecting those dots and we're pulling in the correct problem or diagnosis code. We also want to make sure, as I said earlier, if it's not controlled, that we include that diagnosis to describe why it's not controlled with hyper or hypoglycemia. Now, one other thing is sometimes I will find providers documenting throughout their note history of diabetes. In a coding world, when you document history of, that means it is historical, no longer exist. For example, I was in the hospital, I had a pneumonia. My pneumonia is completely gone. I'm seeing you in follow-up today. I had a history of pneumonia. If I'm diabetic, I'm taking medications and I'm at goal, I don't have a history of, I have an active diabetic complication or diabetes diagnosis. I might not have any complications, but I have the diabetes, even though it might be well controlled. It's not a history of. One area in the assessment where I find providers struggle, which can impact the complexity of the patient, is they're pulling over from the problem list. So, for example, if I used to be a diabetic that was pretty normal at goal, didn't have any complications, E11.9, but later on, things happen. Now I'm not at goal. I've got hyperglycemia. Maybe I've got some neuropathy. If that is not on my problem list, providers continue to pull E11.9 over. So we'll talk about how to fix that when we get a little bit further into the presentation. Plan. This is a specific and concise treatment plan that you have outlined for that patient regarding their diabetes. Is it including taking their medications they're already on? Are you increasing a dose, decreasing a dose, adding another medication, changing a medication? Are you ordering lab? Are you sending them to a dietitian? Are you giving them exercise and diet recommendations? All of that information should be documented. And then when should they follow up? Follow up in 3 months for diabetes. So your team can make that follow-up appointment appropriately. So when I have complications, we need to make sure that that is also clearly articulated in the assessment plan. From a coding perspective, there are some cause and effect relationships. So if you are looking, which I know providers are not, looking in the ICD-10 book, if it says, diabetes or such and such due to the diabetes or associated with or secondary to, in a coding world, that means we can connect the dots and do a combination code. So for example, diabetes with chronic kidney disease. You don't have to specify that for us. If you say the kidney disease is unrelated to the diabetes, then we would not report diabetic chronic kidney disease. However, with this cause and effect relationship, most health centers don't have a coder sitting there looking at every note. And we would not recommend that anyway. It's not cost effective. You're not getting a good return on investment. So providers need to make that connection in their documentation to make sure that diagnosis goes out appropriately. When we're thinking about complications, before we go into this slide, anytime that you see other specified. So, for example, there is a diabetic code E11.69 that says diabetes with other specified complications. That means that a payer or an auditor, we are looking for 2 diagnosis codes. The diabetes with other specified complications, and what is that complication? So that means you as a provider have to document that complication. I am finding when I do chart audits and when I shadow providers, somewhere along the line, they've gotten this misnomer that they should just report E11.69, and that's going to take care of all the complications the patient has. That is not an accurate statement. If there is a more specific diagnosis, diabetes with circulatory complications, diabetes with neuropathy, we should be reporting that code. Diabetes with other specified complications should only be reported when there is not a combination code, and you have to specify the complication and you have to code the complication. So anytime you see other specified, they're always looking for 2 diagnosis codes. Always. Okay. So when we're looking at some of these examples, if you look at example number 1, diabetes type 2 without complications. This tells us as readers that your patient is well controlled, everything is good. Obesity, unspecified, means we are not sure if they're over or morbidly obese, what the obesity is due 2, is it due to a drug? Is it due to excessive calories? And dyspnea is a sign or symptom. However, in example 2, it might be your actual patient, but we didn't document to the highest level of specificity. And we see this often when actually the patient is not without complications. Their hemoglobin A1C indicates they've got hyperglycemia. So documenting diabetes with hyperglycemia. When we look at the BMI, are they really obese unspecified, or are they morbidly obese or class 3 obesity? And then dyspnea. Are they having dyspnea because they have COPD? So again, we're trying to tell the story of the patients you are taking care of through our diagnosis codes, because no one knows your patients. Always code the type of diabetic. So is it type 1? Is it type 2? Is it secondary to something else? Always include the complication if there are complications. Those should be secondary. Make sure that if there is a specific complication, you're using the combined code, diabetes with neuropathy. In lieu of, don't report E11.9 followed by a neuropathy code. If the diabetes and neuropathy are related, use the combination code. And then we need to know, is your patient on long-term insulin? Long-term insulin is an HCC code, so that does describe the complexity of your patients for an E&M, but it also goes back to those HCC codes for value-based healthcare. We also want to make sure that we code for those complications when they are documented by you as a provider. So lately, I'm hearing a lot of coders ask the question of, Shelly, my provider's always reporting E11.9, diabetes without complications. However, when I'm looking at the notes, it says either maybe the patient's uncontrolled, or it'll say the hemoglobin A1C today is 10. Can we fix those diagnoses to report E11.65? In a coding world, we cannot do that. Nurses, coders, billers, we cannot diagnose patients. So if the provider does not specify diabetes with hypoglycemia, diabetes with hyperglycemia, we cannot code that. So if I look at your note and you put in the diagnosis of E11.9, diabetes uncomplicated, but I see that you've said the patient's hemoglobin A1C is 10, they're uncontrolled, I cannot recommend E11.65. All I can do is ask the question of, what does this mean? You tell me the patient's without complications, but you tell me their hemoglobin A1C is 10, you tell me they're uncontrolled, what does that mean? And then when you tell me it's hyperglycemia, I can recommend that you report a more specific code. So again, we just want to make sure that providers are documenting it. While the hemoglobin A1C is really helpful, we still need your clinical impression, your thought. That is what's driving the complexity. It is also what is driving that diagnosis to the highest level of specificity. So there was a new code that is effective October 1 of 2025. So it's already in play. It's E11.A. This is for type 2 diabetic without complications in remission. So what does that mean? It's defined as an average blood glucose level of less than 6.5 for at least 3 months after the patient has stopped all their medication related to the diabetes. Has to be documented by you as a provider, and it can't be reported if the patient has diabetic complications. So this type of patient, they've been seeing you for diabetes, they've now gone off of their medications for at least 3+ months. Their hemoglobin A1C has been less than 6.5 for 3 months, and they don't have any complications related to the diabetes. Then you could report E11.A as a type 2 diabetic without complications, in remission. You would not report E11.9 anymore. This would take place of the diabetic code to let a payer know that they were a diabetic and now they're in remission. Okay, before we go to obesity and BMI, does anybody have questions on the diabetes part? Okay, I'll
Shelly,
keep
this
going.
is Maria.
Yes.
When you say if you add I'm going to call it the A code, the remission code,
Yes.
do you know if that removes them out of like the diabetes HEDIS measures, or are they always going to be in there? So for
Oh,
value-based care, are they going to be in that measure still, even with the remission code?
that's a great question. I don't know that. I can look, I won't be able to tell you if it comes out of the HEDIS measure. I don't know that, but I can look to see if it's on the updated HCC codes, um, to see if they've included that. I don't know if there's been an update since October of 25.
Yeah.
I know there was an update earlier this year on the HCC codes, but I think it was before October. So my gut is that this is probably not on the HCC codes in version 28 right now, but I'm not 100% sure.
Okay. Thank you.
Yeah. Okay. I'll keep going. But again, if you have questions, even if it's related to the diabetes, feel free to come off mute or put it in your chat. Okay. Obesity. So the BMI can be documented by any clinician, anybody, your MA, dietitian, etc. The provider has to be the one to document the obesity, the overweight, the morbid obesity, the class 1, the class 2, etc. That can only be done by the provider to diagnose that patient. Our BMI codes should be reported as a secondary diagnosis. So a lot of health centers report the BMI as a standalone code without an E code. Maybe I come in for my sinus and, oh gosh, let's throw the BMI code on there because it's part of our UDS. Right now, we're not seeing payers kick that back, but in the official coding guidelines, it does state that a BMI cannot be reported alone. It has to be included with an associated code such as overweight, obese, etc. So again, just be mindful of that. And it should always be reported as my secondary diagnosis code. They tell us that the BMI has no meaning from a payer perspective without an associated diagnosis. Overweight, obese, morbidly obese, class 1, class 2, etc. Coders, billers, nurses, we cannot infer the type of obesity from the BMI value. So while there is a standard that says, oh, this range is either class 3 or morbidly obese or overweight, we can look it up, but we are not allowed to diagnose. Only providers can diagnose. So we need you to tell us, with that BMI, is the patient underweight, overweight, obese, morbidly obese, class 1, class 2, class 3, etc. Okay, so some other things to consider. Of course, we need to know what the patient's BMI is whenever you're reporting any type of obesity. We need to know what is the cause. Is it drugged from some drug they're taking? Is it from excessive calories? Like, what is the reason? What caused their obesity? And do they have any comorbidities? And if so, what are those? Again, connecting the dot for the reader. So when we look at a progress note, again, remember I said every time that you document and bill, we have to make sure that we have the meat in there. Is it managed, evaluated, assessed, and treated? So this patient's here to follow up on weight management. They've been doing aerobic exercises for 30 minutes a day times 5 days a week. They've decreased their calories by 200 per day. BMI 48.1. Class 3 obesity, patient will increase exercise to 45 minutes a day, resume appointments, follow up in 1 month. So looking at this, we ask, does this documentation include the monitoring, evaluating, assessing, and treated? Yes. How would we report this? we would report the diagnosis E11 point, I think it's 813 for the class 3 obesity. We would report the Z68 code for my BMI, and we would report the code for the exercise counseling. We would have 3 codes with this. Our first code will always be the type of obesity. Our secondary code, the BMI range. So when we are looking at diabetes or obesity and BMI, of course, we need to know the date of the exam, so the date the patient's seen. We need to know their current weight, current height, and BMI. Typically, this is always calculated again from your vital signs. We also need to know, is it due to excessive calories? Is it endocrine related? Like, what's the reason for the obesity? We also need to know if you're going to use class 1, class 2, and class 3, we have to have that instead of overweight, obese, morbidly obese. We know that individuals who have obesity issues are at an increased risk, right, for certain medical conditions. So again, it's going to be important to really document this information to describe the complexity of the patient. A lot of times when I do chart audits, we will find the BMI, but again, there's not really any detail about the type of obesity. There's not really any detail of a plan. A lot of EMRs automatically have a little blurb in there, nutrition and diet discussed with patient. As a reader, that doesn't tell us anything. And when it's on every single patient, it's really hard to determine if that work was actually done. So when you are documenting and coding and billing for obesity and BMI, make sure it's clear. With our value-based perspective, our class 3 obesity, our morbid obesity, and the BMIs related to morbid obesity and class 3 obesity all are value-based codes across the board. They all have a risk score. What I find when I shadow providers and talk to providers is they don't love to put in their note morbid obesity or class 3 obesity because they don't want to hurt the patient's feelings. So a lot of providers will use E66.9, obesity unspecified, which does not risk score, doesn't describe the complexity of your patients. So be mindful when you are documenting, be accurate in your documentation. So when we're looking at this example, we'll say that the patient in the exam, it states that the patient is a morbidly obese, well-nourished female. When we see this, we know that we can code, if we were looking for coding opportunities, morbidly obese, the E66.01, because the provider specified that. We would also go to the vital signs to find the appropriate BMI to code as a secondary code. Now remember, most health centers do not have a coder that can look at all of these notes. It's not cost effective. It's just not a good practice. So we need the provider to pull this information down into their assessment plan. In this second example, in the vital signs, it has the BMI of 52.4. In the HPI, it states that there's an obese female with hypertension and diabetes here for her preventive visit. In this instance, we can, if the provider has not pulled a more specific diagnosis into their assessment, we can only code obesity unspecified. Remember, E66.9 does not risk score. However, BMI 52.4, if the provider does pull in that BMI code, this would risk score. So we're okay on this to get my value-based points because the BMI does risk score. But if the BMI was not anywhere in the note, by chance we didn't do the height today, so we don't have the BMI, and we only pulled over obese, you would not receive credit for the value-based perspective because E66.9 does not risk score. So this is just a cheat sheet for you to look and see what E codes and corresponding Z codes. This first slide is with our original E66 codes: morbid obesity due to excessive calories, other obesity due to excessive calories, drug-induced, with this, I never can say that, sorry, alveolar hypoventilation, overweight, other obesity not elsewhere classified, and obesity unspecified, with our BMI codes, the Z68. Effective October 1, 2024, so a little over a year ago, the ICD-10 book did include class 1, class 2, and class 3 obesity. Why? Well, they did it to improve accuracy for providers to classify the obesity. Again, it gave a better documentation and gave the providers the opportunity to use a class instead of morbidly obese, so that when patients look at their note, they only see the class 1, class 2, class 3. It also allows for more accurate claims data if we're using those codes appropriately. So you can use either code. These codes did not go away. So if you so choose to use one of these codes, you can. If you prefer one of the new ones, class 1, class 2, class 3, you can use those as well. It is your choice on how you want to use the codes. We always need the BMI as a secondary. Okay. So again, with our subjective, as I said earlier, this is the patient's story. So we're looking for information based upon the questions you or your team have asked the patient regarding their obesity. How's their diet? Are they exercising? What are they eating? Do they have any symptoms, etc.? The objective part, again, is your physical exam findings. So might be general appearance. Obviously, their weight from their vital signs is documented. So again, your observations. The final assessment, again, is the diagnosis to the highest level. So is the patient overweight, obese, morbidly obese, class 1, class 2, etc.? Are there any contributing factors? Drug-induced, excessive calories, maybe an association from pregnancy, any kind of complications. All of that should be documented in my final assessment and plan. From the plan, we always want to have a specific and concise treatment plan. What are you telling the patient? Do they need to increase exercise? Do they need to add exercise because maybe they're not exercising now? Do they need to see a dietitian? Do they need to reduce their calories? Do they need to cut out carbs? Whatever you're telling the patient. If you're getting lab work, all of that should be tied together. And then again, when should they follow up? And for the obesity, so that your team can make that checkout appointment that shows the patient will follow up in 1 month for obesity. I can't stress enough how important it is to specify the type and cause of obesity. As I said, when I do chart reviews, probably 8 times out of 10, it is obesity unspecified. Always. Or sometimes there's no E code. There's no obesity link, just a BMI. So again, making sure that it's clearly documented. Obviously, the BMI is crucial for determining the type of and the severity of the obesity. So in this classification of 1, 2, and 3. Again, you have to remember that coders cannot diagnose. So if you put that the patient's BMI is 45, we can't assume that they are morbidly obese. You would have to indicate that. We cannot assume that they're a class 3. Those are things that have to be documented by the provider. So with these new class, of course, there are ranges, but again, we can't, as coders, they cannot go back and look and say, okay, BMI between 35 and 39 is class 2. Providers have to document that information. Make sure that you include any comorbidities or underlying conditions that are impacted by the obesity. So again, let's say that you're seeing a patient, they come in to be seen for knee pain, but their obesity is impacting the pain of the knee. A lot of times when you shadow providers, they're kind of tying that picture together for the patient, but they don't always document it in their final assessment plan. Same with sleep apnea. Patients coming in, they've got sleep apnea. Maybe they're not using their CPAP machine, but the obesity impacts the sleep apnea. Again, it's not always tied together. So if you think about from a provider perspective, whatever you're telling the patient is what you may need to make sure you document. Providers are fantastic at going over the information with the patients, but not always great about getting the dots connected in the documentation. Of course, any clinical person would be able to open that note and look and say, oh gosh, patients here for sleep apnea, they're not sleeping very good. They don't use their CPAP. Oh my gosh, look at their BMI and tie that together. But your payers are not clinical, so they don't do that. We have to do that for them. The ICD-10 codes are also the way that we get credit for that value-based score to describe the complexity of your patient. So if we don't get that information on the claim form, it doesn't show from a value-based perspective the complexity of the patients that you're caring for, the work that you're doing. So again, we've got to identify the cause of obesity. As I said earlier, is it excessive calories? That is the most common cause of obesity. Of course, drug-induced is also a big one, but we need the provider to document that other information for us and diagnose it appropriately. Other causes could be like hypothyroidism. Again, making sure that that information is documented and tied together. If there's any lifestyle factors, they're sedentary, lack of exercise, poor diet. Again, all of that should be documented. So when we look at an example, E66.9, as I said earlier, doesn't have any risk score related to it. If your provider was great and documented the BMI and pulled that down into the assessment plan, we would get credit from a value-based perspective on my Z6841. Again, with the E66.9, I don't get any credit, but I am going to get a score from my BMI. So I'm good. Because those two, even if we had morbid obesity, they're in the same category and we only get credit once. If your provider leaves this training and says, great, I've got it, Shelly's changed my mind, I'm going to be perfect and get it documented to the highest level every single time, that is the best way. Again, both of those diagnoses are on the value base. They both map to HCC score 48. So we only count this one time per visit. So just because we got them both in here, they both score at 0.186, so we get credit one time. So from a value-based perspective, scenario 2 and 3 are identical from a value-based perspective. Example 3 describes the complexity of your patient. So again, they don't map the E66.9. It doesn't map anywhere in version 28. So you get 0 credit for E66.9. Also, related to coding like comorbidities and complications of the obesity, so like the hypertension or the knee pain or the obstructive sleep apnea. Again, make sure that that's clearly documented and you're connecting the dots for the reader. Okay, so before we talk about workflow for diabetes, I want to talk about some workflow discussions for BMI as well. When we are thinking about obesity, we have to start thinking, and diabetes both, I guess I should say, really thinking about your templates, thinking about your support team. So when I look at templates or problem list, that is sometimes where our biggest mishaps come from. So when we are training our team, whether it be for obesity, whether it be for diabetes, we need to teach them how to pre-visit plan. What does that mean? That does not mean, gosh, Shelly, we use Azara, so that's why we're going to use Azara just to take it from there. We want to train your medical assistants. When a patient is coming in for diabetes, I want you to look on the problem list and tell me how many diabetic codes they have. If I'm looking at your patient, I'm like, hey, Dr. Jones, our first patient's diabetic. They've got diabetes uncomplicated. They've got diabetes with neuropathy, diabetes with hyperglycemia. I can remove E11.9 because the neuropathy will never go away. If the patient has diabetes without complications and diabetes with hyperglycemia, I need to leave both because the provider may scare the bejesus out of me and I may get better and be back in goal, so E11.9. But I can remove E11.9 if it's a complication that's never going to go away, neuropathy, chronic kidney disease, retinopathy, etc. We want to train your team. Tell me if they're type 1 or type 2. Look at the medication list. Are they on a long-term insulin? Look at the surgical status. Do they have an amputation status? On the problem list, do they have a diagnosis of chronic kidney disease? And when was their last hemoglobin A1C and what was the value? When I huddle with my provider in the morning, what am I going to say? Dr. Jones, our first patient's here. They've got 3 diabetic codes on the problem list: diabetes with neuropathy, diabetes uncomplicated, diabetes with hyperglycemia. If your team is allowed to remove them, you can direct them. If not, you remove the E11.9. They're on long-term insulin. They don't have an amputation status. They don't have a diagnosis of chronic kidney disease. Their last hemoglobin A1C was 8 on this day. That should tell the provider right off the bat, I need to code for diabetes with hyperglycemia if I don't think that the 8.5 is at goal, unless we have a better one today. I don't need to code the complication of chronic kidney disease. They don't have it. Yep, they're on long-term insulin. I need to report the Z79.4. So again, this is a great way. Just give your team a cheat sheet. If they do this on every diabetic patient, it's going to really start impacting the description of your patient, the complexity, which is going to help your value-based scores. For obesity, again, we want to review the patient's chart, so that pre-visit planning. What interventions were given at the last visit? Were there any labs to be completed? Did they have those labs completed? And then I want to start thinking about any kind of comorbidities. Do they have hypertension? Do they have sleep apnea, joint pain, all of those great things? When we discuss in our huddle, we're going to talk about what their BMI and weight was last time. I want to know from my provider, do you want me to give you a heads up on their current weight and BMI before you go in? Is that something that we're going to talk to the patient about today? Are you going to do the diet counseling and exercise counseling provider, or am I? Who's going to be responsible for that? That's patient specific. We also want to make sure we document the details of the counseling, again, so that it's patient specific. And provider, you're responsible for documenting the final diagnosis. So we have to start thinking, as I said earlier, about our templates. Are our templates helping us from a documentation and a diagnosis perspective? What do you as a provider need to know before you see that patient? Whether it's related to the obesity, do you want to know their weight and BMI today before you walk in? Or do you want to know if I've already educated them, or are you educating them? Same for diabetes. Do you want to know the hemoglobin A1C today? What information do you need? We also want to think about, do you have what I would call standing orders or protocols? This is one area where we do see discrepancies in diagnosis. So, for example, with diabetes, if during the pre-visit planning and huddle, you tell me to get a hemoglobin A1C, or I have it on my standing orders or my protocol, a lot of times what will happen is if E11.9 is on the problem list, the staff automatically link that with the hemoglobin A1C. Make sure during your huddle, if I have multiple diabetic diagnosis, we tell the staff which diagnosis to pick for that patient when they're doing the hemoglobin A1C. Don't always just pull over the unspecified because it's listed there. So provider, you could say their hemoglobin A1C last time was 8.5, use diabetes with hyperglycemia, or they've got neuropathy, use the diabetes with neuropathy. Don't pull over E11.9. We have to also make sure that when we're educating our clinical staff on what to look for, that they know why they're doing what they're doing. So I'll repeat that. We need to educate them on why they're doing what they're doing. The reason we want to do that is because if I'm your nurse and I know how important it is for us to get to the highest level of specificity on my diabetic patients and my obesity patients, I need to know if they have those underlying conditions that impact one of those diagnoses. And Shelley, this is why we're doing this, is because the payers want to know how complex our patients are. So we get credit for that work. Now I start understanding why I'm doing what I'm doing. In lieu of, when we go out and we say to clinical staff, hey, it's really important you do X, Y, and Z. And they're like, yeah, well, I'm really busy. And so providers can do that. They're the ones who diagnose patients. They don't understand that we are a team. It takes all of us. And so when our patients are diabetic with complications, but we just keep pulling over diabetes uncomplicated, or we're not talking about it with the provider like, hey, their BMI today is X. Our providers are coding what's on the problem list, even though they know the more specific. So we have to work together. So it's that pre-visit planning and that huddling that are going to drive your value-based scores up, especially for diabetes and obesity. We've got to know, do they have an amputation status? Because that drives a whole nother risk score as part of your HCC or HCC codes for value-based healthcare. So again, working with our team, working with your templates. And again, you can't eat an elephant in one bite. So that's why we're doing these in sections of probably two. One of diabetes and obesity, one has 3 diagnoses, but 2 or 3 at a time. So you can start working on eating this elephant slowly to get to the highest level of specificity. Also, your coders and billers can help as well. So run reports, who's coming in the next quarter. Have them go through and look, every diabetic patient, even if they're just looking for diabetes on the problem list with a chronic kidney disease, and letting you know, hey, you need to update your diagnosis code because it looks like Shelley has diabetes and chronic kidney disease. So it can be a team effort from your clinical staff as well as your coding and billing staff. They can conquer 2 different things on the same diagnosis to help you as a provider really describe the complexity of that patient. Okay, so I'm going to open it up to questions, comments, thoughts. If you have a really good process you want to share, please do. And this is your time. So if you have questions unrelated to diabetes and obesity, I am happy to take those questions as well. While you're thinking about your questions, after this conference, you will get this PowerPoint. You will also get two hot tip coding sheets, one for diabetes and one for obesity. Laminate these for your providers. I have one provider group, health center group. They are picking out one tip sheet every time they do a peer review. So they are adding the highest level of specificity. So for example, let's say you pick diabetes, they're using that this time, this quarter, to do their peer review. In addition to what they typically look for, they're adding in, hey, are we getting the complications to the highest level of specificity? Are we getting the amputation status? So really to impact the complexity in their value-based score, they're using those hot tip sheets throughout their peer review. So think about that as well. So questions, comments, thoughts? While you're thinking, I can show you what the hot tip sheets will look like. But again, feel free to come off mute. And there's no dumb question. Everybody has probably the same question, but somebody doesn't want to ask it. Okay, so while you're waiting, let me show you what the diabetes tip sheet will look like. Let me blow it up. So the tip sheet will give you the description, the ICD-10 codes. It will also show you the complications. So for example, if your patient has nephropathy, here are the codes that we would use for the chronic kidney disease. If they have ophthalmology complications, here are the diagnosis, description, and codes with the seventh character, whether it's right eye, left eye, bilateral, neurological, etc. So it has all of the different complications for your provider. Also, some diabetic documentation tips. So again, things we talked about today, if there's complications, make sure you're documenting that. Connect the dots. Are they on long-term insulin, etc. We also have diabetes due to underlying conditions, drug-induced, etc. So it gives you the root ICD-10 code, as well as a coding scenario and some information from the American Hospital Association, which I told you that they don't recognize uncontrolled diabetes. So this will also just give you a quick look at, hey, what would my scenario from a documentation perspective look like? And how did I code it? Did I code it correctly or not? And then some other tips there. So this is, you'll get this for every diagnosis that we discuss during the trainings.
Well, it doesn't sound like we're going to have any questions. But if something does occur to you, feel free to email me or I don't know if Shelley's contact information is in the slides, but I can always forward it to her and we can follow up afterward. I did put the evaluation in the link in the chat, and our next session is scheduled for 2 weeks from today, so you can register through our website. Thank you so much, Shelley. That was a really detailed and interesting to me presentation. And I thank you for sharing that with us.
Happy
Thanks
to.
for joining and have a great rest of your day.
Have a great day, guys.